I'm Hsia. I'm a psychologist, which means I have a doctorate in psychology, a PhD, and I specialize in anxiety disorders such as like panic attacks, people who get like strong physical sensations and get worried and can't go places because they're afraid they might pass out of a heart attack, to general worry, a lot of future-oriented worries, to specific phobias like fear of dogs or fear of flying, to things like obsessive compulsive disorder. And that's the other area we do a lot of treatment of, is people have obsessional thinking patterns. They have lots of scary, catastrophic thoughts in their head, and they feel compelled to do some behavior to get rid of that. So at the OC Anxiety Center, that's what we focus our treatments on. And we try to do it in a way that's supported by research. So that's what we've been doing for since 2012 now. So, and we get this a lot, is people will call us and say, I've been diagnosed with anxiety. And very often say, I've been diagnosed with anxiety and depression. So the thing is, with both of those are categories. So they're not a singular diagnosis. So when I say I'm anxious, that's different than if I say I have a specific anxiety disorder. So when we talk about anxiety disorders, we're actually using something called, let me actually copy it right here, this fun book. And this is actually a manual that we use, and this is based on data-driven scientific approach in regards to coming with diagnoses. In the same way that how do we define like diabetes, or how do you define something like obesity or cancer? In that same way, so there's specific markers that people have to hit for different disorders. So with anxiety, we have a classification of disorders, anything like I was just describing, from general worry, a lot of future what ifs, to fear of certain situations. So it depends on what we're looking at. But one way to generally think about any sort of disorder is it interfering and or is it distressing to me? So the level of interference: can I get out of the house? Can I go to my job? Can I take care of my family? Those are levels of interference, to more personal things of like, I'm just not enjoying life anymore. To that goes into the level of distress. I just feel kind of overwhelmed or unhappy. I'm really distraught that I even have to deal with these things. So when we have a level of interference that becomes problematic, I can't get to my work, or work is very difficult for me, and I'm so tired by the time I get home I can't do anything. Now we have an issue, regardless of the type of disorder it is, be it a mood disorder or an anxiety disorder or otherwise. So one of the major things we look for first is how big of an issue is it, and then we start looking at which criteria does this type of anxiety disorder meet for. However, in general, with anxiety disorders, we're talking about a level of worry, either current with how I feel physically, future-oriented in regards to situations that might be specific, like fear of an animal or fear of a specific environmental issue like water, like fear of water or drowning, to just a lot of what ifs. What if I don't make it to college? What if I never get married? What if my wife hates me? What if all of those sort of thinking patterns? So in general, when we talk about anxiety, it's kind of like that typical term we're using is that what we expect, that worry and fear of either current things or future. Rather than trying to relax or work or get away from anxiety-provoking situations, we actually want to learn how to walk through them and learn how to be able to handle them better. In regards to OCD, there's a whole classification of disorders called OCD disorders, but they're typically, when we talk about obsessions and compulsions. So obsessions are thinking patterns. So the way that I'm thinking, and it becomes obsessional. So we're not talking about like once or twice or three times a day. It's like dozens to hundreds to thousands of times a day. This is all I think about. So whenever I see something, that's the filter I see through. So if I'm worried about things, one of the classic ones is contamination. So it's not that I have a thought of like, oh, I wonder if there's something on my hand. Is that I'm scanning the room and looking for things that are dirty. Can I touch that? Should I even walk over there? Did that other person touch it? So there's an obsessional way of thinking that somehow it's so focused on my mind that I can't get out of that. And to lower the anxiety around those thoughts, if I give into some compulsion, then for that moment, it decreases that level of anxiety for just a little bit. However, then the thought just keeps on coming back and back and back again. So when we have obsessive compulsive disorder, I have an obsessional thought, and the types of thoughts can vary from anything from things are contaminated to checking, did I really close the door and lock it, to sexual thoughts that I find obscene or distressing, to religious thoughts about my relationship with God, to harming other people or harming myself. So there's a whole different range of obsessional thinking patterns. and a whole range of compulsions, anything from physical things of I have to tap things in a certain number of times or avoid good and bad numbers, to I have to range of physical things, to we have called mental compulsions, where it's just all in my head and I'm doing things in my head, like counting the number of words that I'm saying and making sure that they don't add up to a bad number. So there's all sorts of different compulsions based on that obsessional thought. But the idea is that compulsion decreases my anxiety about having that thought in that moment. Typically onset for a lot of obsessive compulsive disorders around the age of like right around puberty. So right around the age of 12, 13 is very often we'll see the onset, but it's not the only onset. Um, Same thing with depending on anxiety is a little bit different, so it depends. So very often anxiety can be because of a specific event. So if I have a negative experience flying, that might start my fear of flying, and that could be at any age. We have children as young as 4 or 5 who might come in with an anxiety or OCD disorder. And we have people coming in much later as well, into seniors where they have something like this occur. So the range is pretty broad. In regards to, we see slightly more females than males for a lot of the anxiety disorders. Males, we see a lot more of what we call pervasive developmental disorders like autism and learning disabilities. We see more commonly in males than females. But we see them, it's onset's can be relatively young, and there's the best way to probably think about it is probably a combination of both genetics as well as environment. So when we talk about like a stress diathesis model, is I might be predisposed biologically. So my father is diabetic, so I have a 25% chance of becoming diabetic. That can be affected, however, by my environment and what I do. So if I sit around all day on the couch and eat deep fried lard, I'm much more likely to increase the likelihood of me getting diabetes. If I have relatively good nutrition and exercise habit, I can decrease it, but I still might get it anyways because that 25% just might be enough. So we'll see a lot of that in the same thing with anxiety and mood disorders, as well as OCD would be what's in the environment. So anything from what's being modeled by my parents. So if we have anxious parents, we're likely to have anxious kids. If mom can't handle being around the dog, there's no way I can because mom's bigger and stronger than I am. So I'm learning mom can't handle this, I can't handle it. If mom gets easily overwhelmed or has lots of what ifs, then the world is a scary place. So some of it's modeled. Some of it just might be biology, as well as stressors. So some people break out in acne, other people are going to have panic attacks. So as we look at these things, we're trying to figure out not only kind of what the cause is, but in terms of when we talk about treatment, it's more about how do we deal with those issues. It's good to kind of understand where it comes from, but even if we know where it comes from, that doesn't solve the problem. We actually need to make significant shifts on how we think and how we behave around those. Most commonly, it's a level of interference. Sometimes we'll have a spouse call, and because it's distressing to her and it's interfering in her life or his life, very often we'll have parents call because they'll start to recognize, hey, one of the big things we might have is like school refusal. So that's not a diagnosis, it's a behavior, right? So then when I see the behavior school refusal, why am I refusing to go to school? And that might start figuring, it's because I might have social anxiety disorder. I'm afraid if I raise my hand and ask a question, the teacher will make fun of me, right? Even though that doesn't happen, that's what I'm afraid of. Or I'm going to feel so embarrassed that it happened, I can't go. Or I can't go late. So I have to get up at like 5 o'clock in the morning and then wake mom up at 6, even though school doesn't start to 8 and it's only 10 minutes away. But we're leaving at 7 o'clock because I want to make sure I'm on time because, oh my gosh, it'd be horrible if I'm late because everyone's going to look at me. So we might see like impact at home in that way where the kid's getting up the mom like at 5 o'clock, 6 o'clock in the morning when it's not necessary, to issues at school, to problems academically or socially in or out of school, to in the workplace, I'm having problems advancing. We had one guy literally who got a promotion, was literally moving up in the building, and he had a fear of heights. He couldn't go up to the 5th floor. So we have different variations of why it can be impactful, from anything from a social, familial issue to more of a career financial. There's a couple things to keep in mind. So we have kind of what we call counseling and clinical psychology. So counseling psychology are things like marital issues, mild depression, career choices. And that kind of falls in the counseling realm. And we have like marriage and family therapists, and they're great at those sort of things. And that's what they're actually trained to do. On the other hand, we have clinicians. So we do clinical psychology. So that's what we do. So when we can come up with a diagnosis, now we're talking about a different ballgame. So if we're having like kind of an acute short-term level of worry, something like, oh my gosh, the test is coming up, or I'm going to the prom and it's with my big crush and I don't know how to do this. Those sort of things are kind of common, and everyone experiences those things, and that's something where like mom and dad can step in, or even if it's an ongoing issue for but relatively short, like a semester, that might be something for like a counsel, like a marriage and family therapist to help out with. There's some good workbooks, so there's some self-directed ways that we can help with those kind of short term. But if we see this as a pattern, every single time I go out on a date, or every time I have a test, or every time I have to interact with my colleagues at work, now we're starting to have a level of interference which is significantly different. And it's no longer kind of a counseling one-off thing, it's an ongoing problem that now we might have to do something with a clinician. So we talk about clinicians, then we're also looking for, unfortunately, the field of psychology is really fractured. There's all sorts of different theoretical backgrounds and understandings of how we approach issues. We tend to be very research-based. So we're looking for what the research tells us works. So it's called empirically supported treatment protocols. And the idea is, does the empirical evidence indicate that this is the way that treatment works? So what we know for anxiety and OCD disorders, the primary form of this is called cognitive behavioral therapy, or CBT. So when we look at cognitive behavioral therapy, it's cognitive, so we're changing cognition, behavioral, changing behaviors. Okay, so we're actually working on changing how I think and how I behave. And to do that, we actually focus on, once we understand that it's logically okay to do, then we actually go out and practice doing those things. So rather than trying to avoid dogs for the rest of our lives, we might start by we have one person who couldn't even say the word dog. So we start saying the word dog over and over and over again. Then we start looking at drawings of dogs. Then we start looking at pictures of puppies, to adult dogs, to dogs that look aggressive, to looping tapes of dog attacks, and have them watch that and get used to it. So when they have that thought in their mind, it no longer overwhelms them because they've already kind of seen it, to bringing dogs into session, to actually going to dog parks. The idea is, rather than moving away from our feared objects, is if we understand they're actually safe, we move into that anxiety and normalize it and start to recognize, I'm uncomfortable, I don't like this, and I'm totally okay. Kind of like going through a haunted house or watching a horror film. I don't like horror films. They scare me. But I'm not in danger. I'm not going to die from watching a horror film. Am I going to be scared? Absolutely. If I have good reason to go, so let's say my wife really loves horror films and I want to spend time with her, and that's her choice of what she wants to do. Luckily, it's not. Then I would go. Why? Because it would be worth it to support my wife. Am I going to enjoy it? Absolutely not. Right? But we're learning to get comfortable being uncomfortable. There is treatment, and it is relatively brief. So the empirical treatment protocol that we use for generalized anxiety disorders, 18 sessions, panic disorders, 12. And the idea is, if you're looking for treatment, you should be looking for a provider. If it's anxiety or OCD, that is cognitive behavioral therapy based. And that there's probably something called exposure and response prevention that's going out and doing these things rather than avoiding them. And one really good way to tell is there homework? Are the things that you're doing outside the session? It's not simply meeting once a week for 45 minutes, because it's kind of like learning a new language. You can't learn a new language once a week if I'm only spending 45 minutes. So those are things to look for. And no, I think the hardest part is settling in and knowing that this, in the end, will be okay. Sure, we are. I'd be happy to speak with you. Anyone who has any questions or issues. We also just try to help people. So feel free to give us a call, or email us, or look at our website. Probably the easiest way is just to go to our website, which is ocanxietycenter.com. And we do a lot of pro bono, kind of just take calls, try to direct people, even if they're not within our local area, to see how we can best help you, be it locally for you, or we are doing things web-based. So we can do remote through California. We're licensed in the state of California. So there's definitely things we can help you with, or even direct you in the right direction for getting help in your local area as well.